Well, I knew since I was very young that I was going to become a doctor because I guess my dad was a physician and his father and his brother and everybody. So it's a long history. And of course, I wanted to emulate my dad. But myeloma, I was first year of fellowship and just my first month rotation, I didn't know anything about blood cancer, very little, coming up of residency. And I was called for a consult, patients with newly diagnosed myeloma. And I tell you the truth, I really didn't know anything about. So I went to the library and back then, because I'm quite old, we didn't have Google and everything. And I read about myeloma and the average age was about 70-ish. And when I went to meet with this patient, it was a young woman, 42 years old, and she had spent actually 20 years of her life in Italy. So we were conversing in Italian, I'm Italian. And I was fascinated by that, by the story, and I started to read everything and to make the proper recommendation at that time. And at that time, the autologous transplant was definitely increasing in terms of becoming almost a standard of care. And allogeneic transplant, we didn't have anything. We didn't have the new agents. And from that, it became a love-hate affair, I guess, with this disease. Yeah.
I'm the first doctor in my family. I was kind of drawn to this kind of romantic, noble notion of being a physician to help patients. And I knew I wanted to do oncology, hematology, but wasn't sure about surgical or the medical side until I scrubbed into my first Whipple procedure in medical school. And after 14 hours of holding retractors, I realized this is not for me. And then I did my internship and residency at a hospital that no longer exists called St. Vincent's. And it was an epicenter of myeloma with people like Sundar Jagannath, Ajay Chari, David Wiese. And my first day on the oncology ward, when I get up to the floor to see the admitted patients and understanding that myeloma is less than 2% of all cancer, the hospital is very known for HIV and myeloma. And normally an inpatient floor will be lung cancer, colon cancer. But because it was HIV, the first 3 patients had Burkitt's lymphoma, another rare disease, and every other bed was myeloma, which is just a very strange thing for an oncology floor. And I got to see world-class people treating a complex disease, and I found that fascinating, that the field was in this earlier phase of evolving, exactly as Dr. Gasparetto talked about. The older days, there was little we can do. In the last 10, 15 years have been an explosion of options, and it just seemed like a place where you can make a huge impact. So I got hooked.